you are welcome to today's video. My name is Dr. Henry Aisagboyin, and today we are continuing our discussion on health program planning and evaluation, and we are treating evaluation of health programs. Once again, my name is Dr. Henry Aisagboyin. You are welcome to today's lecture. We've treated part 1, part 2, and part 3, and today we're looking at the part 4 continuation, and I believe that you have listened to the first part, second part, and the third part. However, if you have any challenge, perhaps you've watched and you didn't understand one or two things, feel free to write me, feel free to send your questions to me. And my students, I believe that you have done the assignment for part 1, part 2, and part 3. Remember, you have to drop the assignment on the comment section, and not only dropping it there, do not put your name, you can just put your mat number. I will take my attendance when I need to. Today, we are talking about evaluation of health programs, and we are looking into it, to discuss types of evaluation, evaluation designs, data analysis, and interpretation. We want to see the feedback that the system brings, and then we want to see the group project framework development. Now, these are the index that we are looking at: introduction, definition, the key concept, types of program evaluation, the theoretical framework, evaluation design, and all that, as you can see. Now for introduction. Introduction now. Evaluation is a systematic objective assessment of the design, of the implementation, and outcomes of a program. Unlike monitoring, an ongoing tracking process that flags immediate implementation problems. And so evaluation, as you've seen, is a systematic and objective assessment of the design to look at the implementation and the outcomes of a health program. And unlike monitoring, it tracks the activities continuously. Evaluation asks deeper questions about the relevance of the objectivity of that project. It asks of the effectiveness. It asks questions about the efficiency. It wants to find out the sustainability and the impact. Evaluation informs policy decisions. Evaluation informs policy decisions. Very important, because when you evaluate, you get data, you get information, and those information help to inform policy decisions. Program improvement. You scale up the choices. Amidst many data, you can make the right choice. It also provides accountability for donors and governments, ensuring that proper accountability is given, because the program or the progress is monitored, evaluated, and checked from time to time. In Nigeria's complex health system, characterized by multiple funders, decentralized delivery, variable data quality, and socio-cultural diversity, evaluation protects scarce resources by identifying what works, what does not work, and why it is so. So you see that the advantage of evaluation is very important. Now put it this way: evaluation is simply about probing, looking into a particular project, what is being done. You assess the design, you look at the implementation, how it is being done, and you look at the outcome. And so we evaluate everything together to determine if indeed it has met its purpose, or the purpose have been defeated. Now let us see the key purposes of evaluation. The key purposes of evaluation. Key purpose of evaluation: it will improve your program implementation, and it will ensure that there's accountability. Evaluation, when it is done, it will guide the allocation of limited resources. It will also inform health policy decisions, and it will demonstrate effectiveness to funders, giving them the assurance that they can keep funding the project and have no fear of corruption. It will also generate generalizable knowledge that can be transferred in form of research and application somewhere else. Let's see the definitions one by one. Now, evaluation can be defined as a systematic assessment that uses appropriate designs and data to judge program merit, value, and the impact. We are using appropriate designs and data to be able to judge the program merit, value, and impact. Evaluation differs from monitoring in scope because it answers, did it work, and why did it work, or why didn't it work. Method, it uses baselines, it compares groups, and also uses mixed methods so that properly it can be evaluated. Let us look at the key concepts. The key concepts: number one, we have the program effectiveness. 2, process evaluation. 3, outcome evaluation. 4, impact evaluation. And 5, evaluation design. Now let us look at the terms. When you say program effectiveness, it is the degree to which intended outcomes are achieved in the real program context. External validity matters here. Now, it will distinguish from efficacy, which is performance under the ideal condition. In the ideal condition, it will check whether if this project is taken to another place, if it will still perform, looking at the background, looking at what has been in place. And so we want to see that, assuming everything is provided, what is the extent of achievement that we are supposed to get? So we want to be sure that despite when everything was provided, we didn't get a suboptimal outcome. So we want to see the program effectiveness. For process evaluation, it examines implementation fidelity, the trust. Did they really do what needs to be done on implementation on a daily basis? Did they reach, the extent to which they ought to reach? The dose delivered, were they received? And the content, they want to be sure that the context of implementation is what was exactly put on paper as planned. So you want to be sure that it was not changed or used for a personal benefit. It has to explain whether a program failed because it was poorly implemented or because the intervention itself was ineffective. So we want to know, was it a failure in the planning, or was it a failure because of the intervention used was not effective enough? Now, for the outcome evaluation, it measures short and medium-term changes, where we look at the knowledge, we look at the behavior, and whether or not the services rendered was accepted by the community, if there was a good service uptake. The next one is the impact evaluation. The impact evaluation. Now, when you say impact evaluation, it assesses long-term population level change, not a short and medium term. Long-term population level change, and it attributes to the program. So it wants to see what the program had been able to achieve, the impact on a long time. For example, change in maternal mortality attributable to an intervention. The impact evaluation will require strong designs to support the causal claims. So you will need a good design so that all that has taken place, there will be evidence that can point to the fact that, okay, this is the impact of the assessment or the program. And so evaluation will require strong design to be able to support whatever claim that it provides, whether it worked or not. So you must have evidence to prove that after your evaluation, the impact wasn't as expected, or you provide good evidence to show that after the evaluation, the impact indeed provided or was able to, prove that it indeed made impact on the long run. So it's very, very important that you take note of that. So when we say impact evaluation, it's just a matter of proving that the program, okay, it has ended, and we want to see, was there a long-term impact? Whether you say yes or no, you must back it up with evidence. Now let us look at evaluation design, which will be needed to be able to prove the impact evaluation. So evaluation design is the methodology that is the experimental or quasi-experimental, observational or mixed method, that was chosen to answer evaluation questions, design choice balances, internal validity, that is how confidently we can infer causality. Can we say this was the reason, it was because of this program that these benefits came? It was because of the effectiveness of this program that these people are enjoying this, or there was longevity, or there was good health in the community, or a particular problem has stopped. Are you sure that it was because of what the program was able to impact, or was it just mistakenly as a result of something else? So you must be able to conclude and relate it with it. Was it feasible? If you take it to another place, by evaluation design, you have to prove if this program can work if they do the same thing in another place. Is it ethical? Are lives not affected? And can you generalize it? This is very important. It also shows the implication for practice. So what is the implication for practice? That is evaluation. Why is it important? What is implication? Why do we have to do evaluation processes? It is important because choosing the right design and indicators before implementation is critical to producing useful, defendable evaluation findings. So it is important that you have a very good evaluation design so that by the time you are done and you are challenged, you can be able to prove that indeed the result I got after my evaluation is correct. And this is the reason why I use so experimental methodology, either the quasi-experimental or observational study, or cross method in form of observational and experimental, or you are carrying out key informant interview. At the same time, you are using cross-sectional, that is use of questionnaire. Now, putting all this together, you must find a way to prove it. So before you even begin, you have chosen your evaluation design. What methodology are you going to use? So choosing the right design and the indicator before you start implementation of evaluation will determine, it's critical, so that at the end, you can provide something that is defendable. Now, let us see, when do we evaluate? When do we evaluate? You evaluate when you want to measure change. You want to find out to what extent is this change. You want to find out the baseline. That is, what was it before the implementation, so that we can know what was it after the implementation. Also, do you evaluate during the formative period, that is the mid-program, so that you can optimize design and implementation. So during the program, you also evaluate so that you know if you are going to improve the program, or you are going to change design, or you are going to improve the content of the delivery, so that in case something is not right somewhere, you improve it, you change it, so that we can achieve success. You also evaluate at the end of the program. At the end of the program, because you want to measure whether the objectives were met. So you do it before the implementation to see what it was on ground before we even started the project. Number two, in the middle of the program, during the formative period, to see whether there is a need to change anything. Number three, at the end of the program, to be able to determine maybe that the objectives were met or not. Number four, we also want to see the impact. The program has ended. We want to see if on the long run there is an impact. So it measures long-term effects and sustainability. And so the impact evaluation may occur several years after introduction. The point is that we want to see if there was an impact, if indeed it brought about a change in that community. Next, we are going to look at the types of program evaluation. What are the types of program evaluation? So let us see the types of program evaluation. We begin by looking at process evaluation. That's number one. Process evaluation. What is the purpose of the process evaluation? It answers the questions such as, were the planned activities implemented? What was the program's coverage and the planned, extent? the fidelity. Were they done to the core? Were participants reached, or they lied? Or maybe they only reached half of the participant that was planned? What delivery challenges occurred? Were there challenges while the program was going on? This has to do with the process of the evaluation. Now let us look at the key domains. When we say process evaluation, there are some areas that you cannot joke with. Number one, the fidelity. That's the extent the program was implemented as designed. Number two, dose. The dose. How much intervention participants received. Example, number of counseling sessions. We want to be sure because this is key. The extent the program was implemented, was it as designed, fully covered? Number two, we want to see the dose. The dose. How much intervention participants received. That is the number of counseling sessions or the drugs that was given to them or the planned program as delivered, what the packages are supposed to be delivered to these people, were they delivered in totality? Number three, we want to see the reach and the coverage. That is the proportion of target population contacted. Was it the whole population or a partial population? Number four, we want to see the acceptability, participant satisfaction, and perceived usefulness. Was this program really accepted by the people? Was it rejected by the people, or were we forcing it on the people? We need to see if it was accepted. Number five, we want to see the contextual factors. The contextual factors. Now, this simply means the local, social, cultural, economic conditions that affected delivery. Were there cultures that inhibited the delivery of the project? Were there areas that we needed to bend? Or was it fully, completely accepted even by their culture? In other words, making the implementation 100% very smooth without any cultural barrier. Finally, we want to also see the methods and data sources. Were those methods and data sources, that is the routine records, were they supervision checklists? Were they direct observation? Is it key informant interview that was used? Was it a focus group discussion, bringing people together to ask them questions and listen to them as they give you answers? Or was it process indicators? So these are examples of outreach conducted versus planned. Let's look at some of them. As an example, we see that in Nigeria, the long-lasting insecticide net was executed. That is, a mass distribution of these nets was executed. Process evaluation asked whether community mobilization, distribution sites, the micro plan on each day, and voucher systems functioned if there were any problem. And the lessons learned is that if mobilization was insufficient, many households may not receive or use nets despite physical distribution. You see that? If the mobilization was insufficient, it means that many households may not receive the net despite the physical distribution. Thus, we find out that high distributed numbers do not equate to high use coverage. That you distributed to all the houses doesn't mean that they are going to use all the nets. So process evaluation will uncover this implementation gap and we suggest corrective steps that will improve social mobilization, community engagement, and distribution timing. That we went to the community, we gave the mosquito net to all the houses. And it is true that every apartment got a mosquito net. But by the time we carry out the evaluation process, we will discover that the implementation gap was there. And what was the implementation gap? That although many rooms collected the mosquito net, many houses, many apartments collected it, but many did not use it. Rather, some used it for fishing, some used it for sieving of cassava, gari, and so on, while others used it as the appropriate way of using it to prevent mosquito bites. You see that? So this evaluation process will uncover that gap, and that we will now have to suggest what are the corrective steps that we need to take. What are the corrective steps that we need to watch out for so that the next time we distribute, more people will use it rather than just collecting it. So what are the common pitfalls? We discover that conflicting distribution that supply with use, that is behavior, process, evaluation helps to separate supply chain success from behavioral uptake. That there was a supply chain success that we were able to supply, we were able to give to everybody got it. That is a different thing altogether. Process evaluation will show that supply was excellent, but the behavior of the community is a different thing. It will separate the two so that while you are rejoicing that we have distributed, you need to hold on to find out that, okay, these drugs that we gave to them, did they use these drugs? Did they use these nets? They may have come to register. How are you sure that they are not taking those drugs to go and sell it to the pharmacist? And the pharmacist pays them, they sell it, they didn't use it. That way you see that the purpose was defeated. Only few used it, the rest sold it to the pharmacist. But we were happy that everybody got the drugs. Even some people got double ration. Whether they lied or they said they never got before. But the intention behind it, unknown to you who was supplying it, was that they were going to sell it to make money. So you see that it's one thing for the supply, the distribution. It's another thing concerning the behavior. So process evaluation will help you separate the two of them. The issue of the supply chain success from the behavioral uptake or acceptance. Now let's move to the second one, outcome evaluation. Outcome evaluation. What is the purpose of outcome evaluation? It is to measure the short-term or medium-term changes that is expected from the program activities. For example, increased ANC attendance, improved knowledge levels. Number two, what are the typical indicators? Behavior change measures. We need to see what is their behavior, what changes have taken place. We need to measure it. The service uptake rate, did they really accept what was distributed to them, what was given to them? We also need to see the intermediate health outcomes. We want to see what was the outcome after they accepted these services, after there was an uptake of these services. We need to be sure if indeed there was an health outcome. If there were no health outcome, we will know. That is, did they use it after they accepted it? So we see the resultant effect in their health, in the community. Number three, we also want to see the design and method. Remember, for outcome evaluation, we have talked about the purpose, the indicators that are needed. Now we want to see the design and method, because to carry out an evaluation, you must choose a particular design method that you're going to use. Now, in the design and method, they use pre-post comparison with the baseline. What was it before? And they compared it with the now. How did they do that? They brought groups. They carried out cross-sectional surveys, routine data trends. They checked the record. For example, the number of people who had malaria before the program took place. And after the program took place, we want to now see if the incidence of malaria has gone down. How? We visit the laboratories. We check the records of the number of people coming down with malaria. We compare in percentage with what it was before and what it is now. Because everybody was given packets, every family was given packets of the drug, and see if they used it or they didn't use it. If they used the net or they didn't use the mosquito net. Let's see some example. Breastfeeding in Kano State. Breastfeeding in Kano State. That's an example we want to look at now in terms of outcome evaluation. What happened? Community health education interventions targeted exclusive breastfeeding. After birth, don't give the child any other thing, just only breastfeeding for the next number of months. The outcome evaluation measured the changes in exclusive breastfeeding rates at 0 to 6 months. How many people completed 6 months? How many people stopped before the 6 months? We needed to find out all those details. And this is very important. What was the lesson learned? We learned that if rates rose up, it means that evaluation should examine which elements were most effective, because different elements were used, different methods were used. Was it the peer counseling that they spoke to the women one-on-one? Was excuse me, was it that made them to be able to carry out, the exclusive breastfeeding to 6 months? They were more convinced. Was it that we went to their homes to visit the women? Was it that act that made them to be able to do it? Was it the radio, the TV, the media advertisement? Which one was most effective? It has shown that indeed it was effective, but we need to know which of the methods used made it more effective. Was it the peer counseling? Was it the home visits? Was it the use of media that was most effective? Now, if there were no change, what are the possible reasons that made the exclusive breastfeeding not successful? That many of them stopped at 2 months or 3 months. We need to know why. Could it be that it was the intensity was insufficient? Is it that there are cultural barriers in that locality, in that village, in that town? Or was it that there was measurement error? We need to find out. And this will lead to the need for refinement to say, okay, this was the problem. And therefore, we may need to do a community engagement to call the women together, to call the elders, to involve their husbands, the male, to address the cultural beliefs, to address those challenges that have prevented them from carrying out exclusive breastfeeding for 6 months as adequate. So there is the caution when it comes to interpretation. And let me state it here. Outcome changes must be interpreted with cultural and contextual factors, meaning that outcome changes may be influenced by the external events. It could be food insecurity. So that triangulation with qualitative data is essential. So when you are looking at outcome changes after your outcome evaluation, you don't just decide outright and say this is the result. You need to check, is it that this outcome was influenced by certain events? Food insecurity, early marriage, or perhaps the environment, the weather. You want to be sure what exactly had fueled this outcome that have made it more intense, as it were. So when you talk about outcome changes, when you are interpreting, you must consider the cultural and the contextual factors in that locality, because that is what makes it unique. We'll move to the next one, which is the impact evaluation. Remember that we have looked at process evaluation, outcome evaluation, and now we're looking at the impact evaluation. When you say impact evaluation, we are simply referring to ascertaining the long-term attributable changes. So that's the purpose. When we say the purpose of impact evaluation, we are trying to look at the long-term attributable changes in that population health. What has this project, after the whole completion of the project, we want to evaluate what is the long-term impact of that program in this population health. We also want to see if the reduction in maternal mortality was, attributable to that program, to the program that was conducted. The lower HIV incidence, was it because of the program? Many years after the program, the HIV incidence has gone down and the maternal mortality has reduced. We also want to see the challenges when it comes to impact evaluation. Attribution is difficult because many factors influence population trends. Impact evaluations require long follow-up, robust comparison groups, or counterfactual approaches, large sample sizes, and sophisticated designs. So these are the challenges. And these challenges, you must recognize them, because to carry out impact evaluation, you will require a long-term follow-up, 6 months, 1 year, 2 years, 3 years, to be able to see what it is now as against what it was before. You also want to carry out robust comparison groups. You want to discuss with a lot of persons so that whatever outcome you bring will not be premature. You want to get an outcome that is detailed and defendable. Now, what approach should you use in carrying out impact evaluation? Randomized control trials. Although this is rare for population impact, but it is the best. Phased rollouts, allowing comparisons, difference in differences, interrupted time series analysis, synthetic controls. These are all kinds of approaches that you can use to carry out impact evaluation. Randomized control trials, phased rollouts, allowing comparison between the beginning and the end, or what it is now and the initial state, the difference in differences. Okay, this is the differences, but what are the differences within the differences? That is, what it is now, what it is then, what are the things that have changed, what has not changed? And then interrupted time series analysis. So using time series in form of 6 months or 2 months or 3 months time interval to see what has changed. Let's look at a clear example in Nigeria. That is polio eradication impact. That took place in Nigeria. What happened? Polio eradication programs combine immunization surveillance and social mobilization. Impact evaluation looks at long-term population immunity, which is seroprevalence, and the incidence decline. And we saw that with this polio eradication program, indeed a combined immunization surveillance and social mobilization, which gave a lot of impact. And so we saw that the incidence declined. What was the lesson learned? There was sustained high immunization coverage plus surveillance detection, which was done sensitively. That is, they took time out to look through the entire community. The surveillance was tight, ensuring that every child took that vaccine. Very important. And this was necessary. And we saw that because of the impact, it was attributed to long-term decline to the program. It was attributed that the long-term decline in the incidence was because of the success of the program. So impact evaluation must assess surveillance quality and external immunization campaigns that may influence outcome. That's the role of the impact evaluation. It must assess the surveillance quality and the external immunization campaigns that may influence outcomes. What are the key points? Impact studies must carefully document every alternative explanations, secular trends, and concurrent intervention, meaning that in the process of your impact evaluation, you must document every information you get. Every alternative explanation that could give reasons to whatever had happened, you must write them down. Whatever secular trend that people talked about, maybe it was rumored at the time, you must write it down. And whatever concurrent interventions that people also used, you must write it down. This is important so that you can have a correct impact evaluation assessment. Now we want to look at the theoretical frameworks. The theoretical frameworks is important so that we'll see the foundation, what was used, what kind of models. Number one, you have the logic model, which is organized this way: inputs, activities, that you make the supply of the resources, it is used properly, and then we have the output, and then we have the outcome, that is the short term, medium term, and then you have the long term. So the logic model is used to clarify theory of change, what has happened, select indicators that are very, very much important to be used, and to guide evaluation questions. What questions should we be asking so that we know that we are going to get the right results? You also have the Donabedian framework. We've discussed that both in the part 2 and part 3. The Donabedian framework talks about the structure, the process, the outcome, and is useful for quality of care evaluations. You also have the RE-AIM framework. The RE-AIM framework. What does it mean? R for reach, E effectiveness, adoption, implementation, and maintenance. You reach out to that community, you find out how effective it was, and what could be adopted, what was implementable, and then how was it maintained. This is useful for scale-up and sustainability even in the future. As an application tip, you choose the framework that best matches the evaluation question. The questions that you have set that you intend to achieve to find out what and what as to answer to those questions, which are clear indicators, you have to choose the right framework that will help you achieve that. Logic model for casual pathways, Donabedian for quality, Re-aim for scale up, and public health impact. So if your question, excuse me, if your question is about the causal pathway, that is what led to what, you use the logic model. If your question is about quality, what was the extent of the quality, the fidelity of the implementation of that program, you use the Donabedian, model. If it is that you want to see the possibility of scaling it up, repeating that same program somewhere else, and wanting to achieve the same public health impact, you use the Re-aim model, framework model. And so that's about it. Now let's see the evaluation designs. The first one is the experimental designs. The first one is the experimental design. This is the strongest internal validity. Nobody argues with this. It's often impractical or unethical for large programs. Number two is a quasi-experimental design. These are designs that you use. Now, when you say quasi-experimental design, it is a non-randomized design that uses external comparison groups or time-based comparison to what approximate causal inferences that this led to this. You need to be sure. So you want to prove that the reason why this took place was because of this process, or was because of these findings, or was because of this activity. That was what led to these changes. So you use the quasi-experimental designs to do that. Now, what are the examples and methods that you will use? I'll give you the methods, I'll give you some examples. Number one, non-equivalent control design. Non-equivalent control group design. This will compare the intervention LGAs to similar non-intervention LGAs. That is, it happened here, it didn't happen here, in different local governments. You want to check what was the intervention and to what extent result was achieved. It will require careful matching on baseline characteristics. Number two is interrupted time series. This will analyze the outcome trends before and after intervention. You also want to check the difference in differences. That is another method. The difference in differences. This compares the changes over the time in intervention and comparison areas controlling for baseline differences. You also have the propensity score matching. The propensity score matching. This matches individuals or communities based on covariates, that is, some relationship, to create balanced comparison groups. But you don't need to give yourself a lot of headache about this. But just know these methods. The non-equivalent control group design, interrupted time series, the difference in differences, propensity score matching. So that is that. Was it applied in Nigeria? Yes. It's widely used because many programs are rolled out and you have non-randomly or at scale. And so when these programs are rolled out, you use any of these methods to be able to design it and to ensure that it is well implemented. So these are the methods under the quasi-experimental design that are used. We'll move to the third one, which is the observational and mixed methods. The observational and mixed methods. You have the cross-sectional, that is a snapshot, that is good for prevalence or coverage estimates. It's of limited causal inference anyway. Just, within a place, you just want to look at snapshot, sharp. You want to look at what has happened there and just take some analysis. How about cohort? This is the follow-up of participants over a long time and is suited for outcome evaluation when exposure status is what? Known. How about the case control? It is useful for rare outcomes. That is case control study of maternal deaths as an example. So it is used for rare outcomes. Strengths and limitations. This is feasible and often cheaper. You see here you find the causal claims weaker, without strong control for confounding. That is, there are claims, but the confounding truth or theory to it is weak. You can't really prove it. That this thing you are saying that was caused because of this, you can't really prove it. You can only just assume, because the causal claim evidence is weak and cannot really prove it. The next one is the mixed methods. It explains what changed and why. This time you are using any of these two together. So it will help you know what has changed and why, because you are checking the rationale, you are checking the approach, and you are checking the value. When you say rationale, why has it happened? What caused it? Why did it happen? Was it due to this and this? The approach, before it happened, what led to it? What informed it? The value, when it happened. Does it look like it was accepted? Does it look like it was the norm? Did it even move the people at all? Did it bring about any change? Was this change spectacular? Was it effective? And others. Now let us go to data analysis and interpretation. Because after you have carried out the evaluation, you get your data, you have to analyze them and interpret them. So we'll look at quantitative analysis first. Quantitative analysis first. Now, as a recommended approach, descriptive statistics, there you talk about frequency, you talk about proportion, you talk about means, median. They are all used to summarize baseline and outcome measures. The next one is comparative test. Comparative test. So these are the recommended approaches under the quantitative analysis. We have looked at the descriptive. Now you have the comparative test. Under the comparative test, you have the t-test and the Mann-Whitney U. Now, the Mann-Whitney test compares means between two groups. It compares the means between two groups. You also have the chi-square or the Fisher's exact test. It compares proportions. You have the ANOVA. The ANOVA compares means across multiple groups. So this is very, very important. You also have the regression models. Here, you want to check for the confounding and estimate adjusted association. You want to be sure to what extent is this responsible for this change. Is there really an association? Was there a strong relationship between the cause and the impact? So that is that you have the regression. Under the regression mode, you have the linear regression, logistic regression, Poisson or negative binomial regression. Then you have the multi-level model. Interrupted under the multi-level model, here you are accounting for clustering. Patients within clinics, villages, within the local government. You want to check what is common in this clustering. And you use it for programmatic data, and it must be modeled. So that at the end of the day, there is proper hierarchy. Now, this hierarchical model will help to be able to know which one comes first and which one comes last. Now, we look at the interrupted time series. This is multiple observation before and after the intervention are taking place. And we have talked about the difference in differences, power and sample size, consideration. Here, you plan the sample size before the data collection so that you ensure that the study can detect clinically important differences. You don't use less amount of population size because in the end, your results will not amount to anything. It will be insignificant and cannot be accepted as an inference. Let's look at the next one, qualitative analysis. Qualitative analysis. Here you have the data collection method, key informant interview, focus group discussion, in-depth interview observation notes, and thematic analysis triangulation. This is all the data collection methods under the qualitative analysis. While under the quality assurance, which is very important, you are having a control that will be used to compare, to check all these data when you collect them. So what is the analysis steps for thematic analysis? You transcribe the interviews verbatim, word for word, whatever the interview the respondent have said. After recording it, you transcribe it verbatim, word for word. Then you familiarize with the data. Then you code the data. What domain can we put it? You express the whole word that he has said in one word or one term or one phrase. So you deduce it and code it. Then you develop the themes and the sub-themes. And so at the end of the day, you triangulate with quantitative results. You say, okay, this one was talking about this one was talking about that. For example, you are asking a question about, patient satisfaction in cancer care. And so all their complaints, some is about finance, some is about drug, some is about bad, how will I call it now, unsatisfactory kind of approach by nurses or doctors. Some of them is distance, some of them is the amount of money they spend, some of them is the unavailability of drugs. So you itemize the summary of all that they are saying, and then you triangulate it with quantitative results, and then you present it illustratively with quotes using good context. So you present illustrative quotes with context so that we will be able to understand that, okay, amongst all that was said, 80% agreed on finance, 60% complained about drugs, 10% complained about, unsatisfactory kind of patient experience, and so on. So that's how you go about the analysis steps for thematic analysis. Now we want to look at the interpretation principles. Here you compare with the baseline, what it was before and what it is now. Then you consider the targets. Then you distinguish statistical versus practical significance. This is what we got statistically. Now, practically, what was the significance? We now have to distinguish it. We do not discard. We got this, but actually, on the ground, practically, it looked very significant. But when we did our statistic, it was not significant. So that you didn't get a statistical value doesn't mean practically it wasn't significant. But that will only determine to prove to you that yes, it was practically significant, but statistically, it really didn't get to that significant level. So you have to account for the context, you have to apply equity lens. That's very, very important. Now let's look at the feedback for program improvement. The feedback for program improvement. Let's look at that now. Feedback for program improvement. Because in pursuing program improvement, there will be feedbacks, and these feedbacks are needed. And as much as possible, you must know how to carry out the feedback mechanisms. Now, for the feedback mechanism, evaluation should not stop at reports. It's not just about writing your reports of what you have evaluated and what you got. A robust feedback loop ensures finding informed action. So what are the feedback mechanisms? Number one, review meetings. Number two, policy briefs. That is, you give a concise evidence-based document highlighting your recommendation and implication for policymakers. Number three, your performance dashboard. This is where you see the visual display for those who send it to the DHIS. Then we have the supportive supervision. This is where your supervisors use the evaluation findings to target capacity building. They also have the training updates. We're talking about the feedback mechanisms now, how those replies are given, how those feedbacks are issued, how they are used. And then you have the community dissemination. An example is the state review meeting under the National Primary Health Care Development Agency. What happened? We see that the state convened the SROM, that is the state review meetings, where immunization and routine program indicators are presented one by one. They looked at the bottlenecks, they identified them, and then they saw the action points and agreed on what they are going to do as action points going forward. What were the lessons learned? We saw that there were regular structured SRMs translating into evaluation findings, and this translation became a concrete operational decision. That is, all the micro planning had to be adjusted, resource allocation need to be checked so that they can reallocate it properly, and this helped to foster program improvements. And it gave about a good practice. What was a good practice? It created a concise management response plan such that it became better than the past. With assigned responsibilities this time, deadlines were given and indicators to monitor the uptake of evaluation recommendations. So at this juncture, you see that it has improved because they've met, they've taken decisions, and based on the findings, they have decided to improve the past policies so that it will be in tandem with what was observed. And it is a plus, a win-win for everyone to improve the uptake of evaluation recommendations. Now let us look at group projects so that we can learn how to develop an evaluation framework. Because that's where we are going. You need to know how to develop an evaluation framework. So let's see a group project overview. What is the task? Develop an evaluation framework for modern family planning uptake in Oyo State. Develop an evaluation framework to find out the modern family planning uptake in Oyo State. Was it effective or not? Now, this includes evaluation questions, what logical model that you used, the use of your model, in this case, logical model, the indicators that you used, the design that you used, the data sources, where did you get your data from, what analysis did you use, what ethics did you follow, and what was the feedback plan. Here you can see an expanded sample M&E table, and please, you must learn this so that you'll be able to reproduce it. You can see here the indicator, you can see the level, the data resources, where they got their data from. You can see the frequency, the method and the design that was used, and who was responsible for what, and what was used. You can see the process. That's the evaluation type. This was process, outcome, impact, process. So you can study it from here, like that, level, the data source for this indicator. So you ask your question, and then you begin to find out the detail, what level, what data source was used, how frequent was it, what method design was used, what was the responsible, who was responsible for what, and who was to check it, and who is checking it, and who is giving the report. And then you also see how it was used. So take time and study this. It's explanatory, it's easy with what I've just told you. Now let's look at some case scenarios. Let's look at some case scenario so that we have a better understanding. We'll take the case of Bayelsa, the long-lasting insecticide net program. Now we'll treat a scenario under the following guise. What evaluation types are appropriate? We'll check for that. You see, we're asking our questions now. Evaluate questions to ask, recommended evaluation design, the data collection plan, analysis plan, interpretation recommendations, lesson learned. Now, this is a very good way to carry out your evaluation. In case you are asked to do that, we want to evaluate this program now. These are the things you need. What evaluation types are appropriate? Evaluation questions to ask, recommended evaluation design, the data collection plan, the analysis plan, the interpretation and recommendation, and the lessons learned. These are very, very important, and we need to find them out so that we can carry out a proper evaluation. Now, we go to the next slide. Here you can see the scenario. I read. The long-lasting insecticide mosquito nets were distributed to pregnant women after 1 year. Malaria incidence declined by only 5% despite high distribution numbers. Evaluation revealed poor community usage practices, lack of behavioral change communication, and inconsistent follow-up. Question. Now, number one, we are now carrying out the evaluation. What evaluation types are appropriate? Process evaluation, outcome evaluation, impact evaluation. For process evaluation, it will be to assess distribution coverage, quality of mobilization, post-distribution follow-up, supply chain integrity. Remember, it's dealing with the process. For outcome evaluation, it is to measure the LLIN heads use, that is self-reported, if they use it, or direct observation, people saw them using it, and intermediate outcomes. That is, did it reduce mosquito bites at night? So those are the outcome evaluation, short-term, medium-term. Now the impact evaluation, if data is allowed to be collected. Now, assess malaria incidence trends. We need to look at it. We need to assess it through the data from the laboratories and so on, and attribute the change controlling for secure trends. So secular trends, I mean. Now we want to see what is the current trend, the incident rate from the results in the laboratories, and we want to attribute it, the change, to check what is happening secularly. So if you have the incident trends, we can now compare with what is happening secularly, and this will require robust comparison of data from time to time. So that's how you know which one is appropriate. Now, B, evaluation questions to ask. These are the questions you need to ask. Were the nets distributed to the intended beneficiaries, that is the household and the village? What proportion of recipients report sleeping under the mosquito net the previous night? What barriers prevented proper use? Is it that there were holes? Is it that there were heat or cultural sleeping practices? What were those barriers that made people not use the mosquito net? Was there adequate community mobilization? Were follow-up visits made by the health workers to go and find out if they are enjoying it using the net or that there were problems, so that to encourage them to use it? Number 6, did other malaria control activities, that is the indoor residue spraying, seasonal chemotherapy prevention, were they taking place? Or did they change concurrently? Did the surveillance system detect and report malaria cases consistently? All this we need to check. Very, very important. Now, we look at C, the recommended evaluation design. Mixed method, comparative component, interactive time series. These were the ones that were used. Why? In the mixed method, we needed quantitative household survey. We needed to ask questions. And then we needed to combine it with qualitative. That's asking questions and taking data. So you give them a form, they fill the form to have the information, then you interview some people by using key informant interview to explore the behaviors and to know the barriers. Then for comparative components, if it is feasible, you need to identify similar communities without the distribution to find out that in this community, what was the difference between that community, so that will be for difference in difference analysis. To find out in that community where we did not even share the net, what was it like? Compared to these ones that we shared the mosquito net, are they still the same incidence rate? To even if there was any impact at all. Then number 3, interrupted time series, where you use routine malaria incidence data across multiple months, both the pre-post distribution, to assess the trend change while controlling for seasonality. We need to check before and after. We interrupt at this month, what was it? We leave after 3 months, another 4 months, what was it? And we want to be sure that indeed it was not that it picked up at a particular month or it relapsed at a particular month. So it's important that you have this interrupted time series analysis so that you can be able to control in terms of seasonality. D, the data collection plan. Like I've said, you can see quantitative, qualitative, and then the process data. So this is how you collect the data, and then we move to analyzing the data. So that's the analysis plan. For descriptive, you use a cross-tab by socioeconomic groups that you compare the use, the ownership, and you cross-tab it by socioeconomic groups. Comparative logistic regression to identify the predictors of net use. What are those things that made the net to be used or not to be used? You compare using your logistic regression analysis. Then the ITS time series, here you segmented regression adjusting for seasonality. Was it that it peaked during the rainfall or not? We want to know if it was seasonal that brought about the change or the negative impact. Qualitative, you do the thematic analysis, like I've told you, to now analyze which of these complaints. Was it heat? Was it sleeping arrangement? Is it that it was impossible to put the mosquito net, or the net damage? Or is it that the beliefs, the cultural beliefs, which of them did they complain about that was of higher percentage? F, we want to see the interpretation and recommendation. After we have done all this, if a high ownership but low use, intervention should shift to behavior change communication. So we gave it to a lot of people, but they didn't use it. So at that point, we're going to change our plan. We're going to change our intervention. This time, we'll be talking with the women. We have to talk with the men. We have to discuss with the villagers. This time, it's not just sharing the net. We need to now talk to them. That the last time we gave you this net, but you didn't use it. Now we want to talk to you. These are the benefits of using it. The post-distribution counseling must be in place, and the community engagement rather than additional net procurement, not providing additional net. They already have the net. Wherever they put the net, they have to bring it out. And we have to teach them how to use the net. And then we recommend follow-up visits. You don't just give them and abandon them. The community health workers should be able to demonstrate to them how to hang the net and to correct all the misconceptions that, if you use this net, you will die. If you use this net, you will be weak. If you use this net, you cannot give birth to children. We need to correct all those misconceptions. And then we also need to target the equity gaps. If the poorest household the poorest households are less likely to use the net, then supply tailored support. Because if they can't afford it, then we supply them. We repair the ones that they have. We provide hangars for them. And then we monitor with rapid surveys after that these stuffs have been rolled out. After the program has gone, has closed, we need to monitor that community. What is the impact of the program? Now let us see the class group discussion. All that we have learned. There are 5 stimulative questions here, or tasks. And so I'm going to divide the class into 5 groups. So group 1 will give us this solution. Compare outcome versus impact evaluation with a Nigerian example. For example, immunization coverage versus reduction in child mortality. So everything you saw me talk about during that evaluation, beginning from here, where we started the case scenario, for everything here, you are going to replay everything we did there. So you will sit in your group and you provide A, B, C, D, E, F, and you will tell us the lesson that you have learned. So you must reproduce it. So why quasi-experiment designs are common: cultural influences on evaluation in low resource settings, policy influence. So it will stimulate critical thinking. So you have to provide this assignment. When the time comes, you will see the list and you have to submit this assignment. Now, the data quality, validity, and ethical consideration. We have to look at this. Now, when you say data quality, to ensure that the data used is correct, the resources where you got the data is valid, and there are no ethical issues. So every data must have good quality checks, internal and external validity. There are no bias, no mitigation, and it had gone through ethical considerations. Very, very important. Now let us see the practical tools. The practical tools and the templates. Now, A is the sample evaluation process. That is, was the program implemented with fidelity to its design? Did the target population increase use of the intervention? So you can see these questions. These are valid questions that you can use for any program. Did the intervention reduce disease incidence beyond secular trends? Which subgroups benefited least? And which one benefited more, and why? That's why you bring the equity analysis. What were the main implementation constraints that they experienced? B, you look at the example SMART indicators, where you check the process of community mobilization meetings held per LGA per month. You want to be sure that everything was done accordingly or used accordingly. You want to see the output of the planned outreaches conducted per month. You want to see the outcome, the percentage of pregnant women who attended at least 4 ANC visits within 12 months. You want to see the impact. How did it affect maternal mortality ratio? Did it reduce it or did it increase? You want to find out using the SMART indicator. Now, we want to see the practical tools. Number C, continuation, expanded M&E plan template. You want to include columns, indicator, definition, numerator, denominator, data source collection method, frequency, responsible persons, like you saw in the template that I told you to study. So you have to draw that plan and look at that template and you answer the questions there. Then you have to look at your analysis. For qualitative components, the key informant interview, you check it, and then you see your focus group discussions, the questions that you are going to ask them. So what were your impressions of the program? Here you are probing clarity of messages. What factors helped or hindered your ability to participate in the antenatal care? How did families perceive the intervention? Any unintended consequences? What would you recommend to improve the program? These are kind of questions that you asked. And for most of you, will be doing your project very soon, and you have to carry out KI interviews. These are very valid questions that you ask to be able to get good results. So let's look at assessments right now. All that we have learned, these are possible questions for your exams. Why is evaluation important in health programs? Why is evaluation important in health programs? And the answer is very simple. Evaluation determines whether programs are effective, efficient, or sustainable and impactful. It informs improvement, accountability, policy decisions, and resource allocation. Why are quasi-experimental designs common in Nigeria? Because randomization is often unethical or impractical in large public health programs. So quasi-experimental designs have found a way of balancing feasibility with casual inferences. Number 3, why must impact evaluation use strong designs? Because multiple external factors influence population health. So strong designs are needed to attribute or observe changes to the program. Whatever you decide, you must be able to provide good evidence so that you can defend your conclusion. In terms of MCQ, you can see here which evaluation type measures long-term evaluation improvement. The answer here is B, that is impact. Remember, long-term population improvement. A quasi-experiment design is always randomized, non-randomized with comparison groups, only quantitative observational study. I've told you quasi-experiment is a non-randomized with comparison group. The fact that you have seen this comparison group, because the quasi-experiment is designed is ensured to compare with groups what it was before, what it is now, using the groups or mixed methods. Number 3, the logic model is mainly used to do what? The answer is establish causal pathway. So remember, the model is to ensure that the process, the structure, that the model, all in all, is put together to be able to establish what has caused this, what was responsible for that. So it is to establish the causal pathway. Now let's see short answer questions, which will be your assignment. So this is another assignment. Get ready. Define the process evaluation and list 3 data sources. Number 2, describe 2 quasi-experiment designs. I've taught you that. You know that already. So I'm not going to give you the answer. Explain how feedback mechanisms improve programs. You can always go back, check your notes, and make sure you provide answers. You can simply do that by putting it in the comment section of this YouTube lecture video, and then put your mark number so that I can take your attendance. Remember, I don't joke with this. This is the evidence that you have listened, you understood, and you have taken time to learn this. So these are my references. Try as much as possible to get these textbooks. If you can, study them. I think it will do you a lot of favor. By the grace of God, we'll be able to conclude this lecture. We have looked at the evaluation of health programs, types of evaluation, the evaluation designs, data analysis and interpretation. We have looked at the feedback systems and the group project framework development. And I hope that you've taken time to take your notes. And also remember, you have the right to listen to this lecture video again and again and again till you have full understanding. Remember, we all do not have the same assimilation. Some will listen to it the first time, they will get it excellently. Some will have to listen to it 3 or 4 times. Feel free. Go back again and again, listen, and if you have questions, feel free. You can always reach out to me when I get to class. I will answer all your questions. I wish you all the best, and make sure that you take time to work hard. Thank you, and God bless you. Once again, my name is Dr. Eri Asamoy. I'll see you in class. Bye.